Today I'm going to be talking about fixing scaphoids, or when we should fix them and when we should start treating them. The scaphoid is what I like to call an awkward but very important bone. It is a link between the proximal and distal carpal rows, and it acts as a tie rod. And so basically the scaphoid pushes and pulls the distal and proximal rows. And it is awkward but important because without it, your rows don't move independently and your wrist doesn't work the right way. Scaphoid fractures are very common. They're the most commonly fractured carpal bone. They're much more common in men than women. They account for about 11% of all fractures in the hand, and they usually occur by falling onto an extended wrist. We know that the classification of scaphoid fractures is broken down into kind of stable and unstable fractures. Stable fractures of the scaphoid are of the distal pole, as you can see, of the A1, as well as a minimally displaced waist fracture, which would be A2. And the unstable variants would be kind of the oblique fractures of the waist, the comminuted fractures of the waist, the proximal poles, and then the transscaphoid perilunate or lunate dislocation variety. We know that untreated scaphoid fractures lead to non-unions, and that's why this is so important. We know that scaphoid non-unions can lead to degenerative changes within the wrist. As my old mentor from USC used to say, this is a big problem. I'm not going to do the accent today. And what you can see here is that if you leave a scaphoid alone, oftentimes it will not heal, and then it will undergo this defined set of arthritic changes in the wrist, known as a scaphoid non-union advanced collapse. So the goal of treating scaphoids is to prevent this from happening. As far as the timing of treatment of this, we know from multiple retrospective studies from different countries that if you wait to treat the fracture, that they're much more likely to get a non-union. So of the patients that they looked at, up to more than 50% of patients had a 4-week delay in their treatment. And from the one in Denmark in 1988, they know that by waiting 4 weeks to get this treated, you get about a 45% chance of non-union. And I'm sure we've all seen these patients in our clinic where, initially their primary care doctor thought they had a sprain, the x-rays were negative, and they sent them to your clinic 6 months later and they have a non-union. This is a really important study that came out in Lancet several years ago, and it's I think the goal of this trial was to actually show that non-operative treatment of scaphoid fractures is equivalent to operative treatment. But what I like to take away from this trial is that if you treat patients immediately, that they don't get non-unions. So what they did in the study is they took a very large group of patients, over 400, and randomly distributed them into either immediate fixation or aggressive casting. I don't really know what that means. These were all were minimally displaced scaphoid waist fractures, and they followed them up for a year. And what they found is that in the fixation group, they only had 1 non-union, and in the aggressive casting group, they had 4 non-unions. And what they were trying to really push was that you needed to fix at least 73 scaphoids to prevent a non-union. But what I take away from this study is that if you treat these promptly, the non-union rate in the study is just over 1%. So if you can get to these soon enough, whether you cast them or fix them, the patients won't get non-unions. So how do we identify these fractures when they happen? It's really important to know that about a quarter of these fractures that happen will have negative x-rays. So it's very important to have a high index of suspicion for when a patient falls onto their wrist and they continue to have pain over their scaphoid, that you need to either follow them up with a subsequent x-ray or go on to advanced imaging. We know that MRIs have near 100% sensitivity and specificity for scaphoid fractures, and that CT scans are a little bit lower at about 72%, but 100% specificity. So if you have a negative x-ray and the patient still has pain, it may be a good idea to get advanced imaging just to rule out them having a scaphoid fracture. Okay? So once you've identified that somebody has a scaphoid fracture and you've decided that you want to fix it, which is a whole other discussion, how do we do this? This is usually done with cannulated headless compression screws. This can be done dorsally or volarly. This can be done through a percutaneous or an open approach. And we know that with the screws that we use, the conical design, such as the AccuTrack screws shown here, provides more compression as compared to the kind of classic Herbert screw. The most important part about fixing scaphoids with cannulated screws is the location. We know that centrally placed screws have greater stiffness and load to failure, and that will allow you to put in a longer screw, which will in turn have less fracture fragment motion. So the longer the screw, the better. All right. We know from other studies that it's much easier to put in a screw from a dorsal approach as opposed to volar, to put it into the central axis of the scaphoid, but there is no difference in vivo in healing rates between these two techniques. We also know that during percutaneous volar insertion, that almost a quarter of the time you actually need to go through the trapezium to put it into the central axis of the scaphoid. Okay. This is just a demonstration of what I like to do in the OR. This is a technique that was originally described by Joe Slade, and it's just the way you put in a dorsal percutaneous screw. So what you want to do is you want to identify your scaphoid and then pronate your wrist until the scaphoid moves from the kind of the kidney shape that you see classically to a cylinder shape, which you see at the top left. And once you see that cylinder shape of the scaphoid, you want to flex the wrist down until you see that ring. And I put a little dot in the center of the ring. That is the central axis of the scaphoid, right? And that's where you want to put your percutaneous wire over. Once you get your starting point and you drive your pin in, and then you can check your other views to make sure you're within the center, okay? This can be done also volarly, which is a little bit trickier to do because you may need to take a piece of the trapezium out to get the starting point in the center of the scaphoid. All right, so here are some cases. This is a scaphoid dislocation. This is a 24-year-old that I treated in the last year. I really like this case because while immediately your eyes go to the distal radius fracture, you don't want to miss the scaphoid that he has. So he fell off his mountain bike and has this very high energy injury. So I took him to the operating room and I fixed his distal radius with a volar locking plate. And then I actually did a dorsal percutaneous approach and inserted a headless compression screw. And you can see at 3 months, both his distal radius and his scaphoid are healed. And the last case I'm going to talk about, this is a 55-year-old right-hand dominant male who worked in biotech, who was in a motor vehicle accident and was seen in the emergency room. He had an injury where his hands hit either the dashboard or the steering wheel, and he continued to have wrist pain. He was seen by his primary care doctor, who didn't get another set of x-rays, but sent him to physical therapy. When he eventually complained enough, he was sent to my clinic at about 1.5 years after the injury, and you can see that he developed this scaphoid non-union. So I took him to the operating room, and I did a volar approach open with just a non-vascularized distal radius autograft, and you can see that his fracture healed after about 4 months. All right, so the take-home message for scaphoid fractures is identifying them is key, and then prompt treatment is key, whether you decide to cast them or to fix them with the screw. All right, thank you very much.